Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you everyone for coming in for today's webinar. My name is Khairul and I will be the moderator for the first slot of today's webinar. Before I continue on further, I would like to share with everyone a quote from the Director General of the World Health Organization, WHO, Dr. Tedros Adhanom. Pandemic is not a word to use lightly or carelessly. It is a word that, if misused, can cause unreasonable fear or unjustified acceptance that the fight is over, leading to death and unnecessary suffering. So, as we all know, more than a year ago, on the 18th of March, the Malaysian government had imposed the Movement Control Order under the Prevention and Control of Infectious Diseases Act 1988 and Police Act 1967. So the title of today's webinar is Remote Psychological First Aid, rPFA, during COVID-19 pandemic, identifying the unmet needs among healthcare workers in UMMC. As I mentioned earlier, my name is Khairul. I work as a psychological officer, clinical at the Department of Psychological Medicine, UMMC. With me today is the speaker for today's webinar, Dr. Zuraida Ahmad Sabki, Senior Lecturer and Psychiatrist, Department of Psychological Medicine, Faculty of Medicine, UM. Dr. Zuraida, if you are ready, I'm going to stop share my screen and you are able to share your screen and continue on with the presentation. Thank you.
Thank you so much, Mr. Khairul, for your kind introduction. As we all know today that we will be discussing on a very important topic that we have initiated from scratch, actually, in terms of trying to get all the mental health experts to come on board with us. So for today's session, briefly, we'll be talking about psychological first aid. And in the era of COVID, definitely there are a lot of adjustments to be done, both from the provider's aspect as well as the intervention, and therefore we term it as a remote psychological first aid. Briefly, for those who are quite new to this term of psychological first aid or PFA, I'll be using the term PFA from now. It is a part of a psychosocial support program, and it is not on its own. So meaning that when we talk about PFA, we are already talking into both the psychological and the psychological aspect. Although we can only see the psychological, similar to physical first aid, where we see injuries or cuts and bleeding. But in psychological first aid, we probably would not be seeing much of that. Although there's a such term called psychological bleeding, kind of thing. But in PFA, we use, especially during COVID, our ability to observe, which is look, our ability to listen, and not just to hear a problem, but to listen attentively and reflectively, as well as empathically. So it takes a lot of training in order to do that for those who are first time users of PFA. And this is based on these three principles of look, listen, and link. The idea of having these principles is basically to create or to promote a sense of safety for the person whom we are trying to offer this PFA. And from there on, we've come and feeling self-sufficient of the ongoing distress. We are able to link them to the relevant authority or bodies in order to provide what are their immediate needs. So we are talking about within the first 24 to 48 hours, these are the things that we need to address. And this could be accomplished also by working as a team. So you will see later in our presentation that PFA is about teamwork, yeah, and then and this is actually to offer an immediate response with regards to that person's needs. So how do we actually identify these so-called psychosocial needs? And this will be our main topic for today. And we will see how actually PFA or remote PFA, we will be able to achieve this. And in order to identify these needs, first of all, the PFA providers has to form a team. Yeah, as what we have been doing so far for the last 1.5 years, and respond to the needs of the person. It's not our need, but the needs of the person who are in distress. So we are focusing more for today's topic on the healthcare workers in UMMC because we've been tasked to do that for the day one of our intervention. And the idea is when we are able to work together, we hope that we are able to impart some kind of interventions, although it's not really a therapy, but some kind of intervention in order to get the person to feel calm, to feel connected, and to be safe as they know that there are people around them under the same organization who are actually responding to their needs. So usually once they are able to provide that kind of calm and security, then only as a team, we would try to identify whether their needs would be more in the psychological or probably in terms of financial aids or food, for example. So we'll be surprised that during our intervention, we found that there are a lot of other things that beyond us that actually that we would like to highlight in this seminar. Okay, Alhamdulillah, with our department led by Professor Hatim as the head of department in the task force committee. So we were able to come to work together in a smaller committee where we formed from the day one where we were told that most of the healthcare workers, there was cases of healthcare workers got infected or under surveillance or investigation. So within 1 week, we were able to form the team, which we term as psychosocial support team. And the idea is basically within a very short period of time, with very limited experience with COVID, as a team, we came out with we work, we do a lot of meetings, and we brainstorm how are we going to come up with a protocol guidelines that will be used by the healthcare workers in the University Medical Center, and from the relevant resources that we managed to get, we are able to actually produce or develop our first ever remote psychological first aid protocol. And of course, we refer to the existing protocol. In our situation, we adopted the one already in use, for instance, the International Federation of Red Cross societies in New Zealand, where they also came out with this kind of similar remote psychological first aid concept. But in our situation, we were able to gather all of the mental health experts from our department, from the psychological and counseling management unit, especially Puan Sohaila and Encik Johari, medical social officers, nurses, occupational therapists, as well as from other departments. And we are proud to say that a lot of people actually come to us to offer help to be part of the team. And the training was done within the first 3 weeks to say about 2 months, and we were able to carry out within a stipulated time. And at the same time, we also managed to provide this workflow, and this is actually prepared by Dr. Benedict. As you can see here, how we manage to gather most of the data from healthcare workers. As you can see from the flow here, the source of the referral is actually coming from the OSHI, Public Health Department, and Staff Health Clinic. And the referrals would go to the person in charge of the Central Data Coalition Unit, or CDCU, and this is where each one of at that moment we have around 32 in total, 32 plus members in the psychosocial support team, and each one of us would receive in between 2 to 3 cases per week. And the moment we received the notification from the person in charge, we have about 24 hours to respond. And of course, as a mental health expert, we would know that not everyone would welcome our call or our messages. And for those who actually responded to our invitation, yes, we will proceed with the phone calls, and depending on their needs. And some, we are not surprised to say that some actually decline any form of help coming from us, especially from the psychiatrist. This is, I think, that we need to work on this issue. Okay, this is just to highlight about the latest distribution of cases. This is compiled by the Psychological and Counseling Management Unit from Puan Sohaila. You can see that the distribution of cases that was referred for PFA, not necessarily coming to all of the PST or psychosocial support teams. Some directly they will approach the experts in the Puan Sohaila's team. And as you can see that the majority of the cases that were referred to us, 83% of them involve healthcare workers, and 64% or the majority are the nurses, and therefore it is very imperative that the well-being of our healthcare workers is taken seriously. Okay, how do we identify the unmet needs of the healthcare workers? Of course, I would say that up to now, we are unable to come out with the proper figure or any statistical information. But as in most of the literature, in finding or understanding the unmet needs can be actually done based on the self-report of the healthcare workers. So, but however, I would like to highlight few challenges that we faced while conducting our PFA remotely from the day one itself. And we realized that most of the cases that were referred to us reached between 3 days to 5 days after they were confirmed to have COVID positive. And of course, if we were to look at the acute distress reaction by anyone who've been told to have COVID positive, by the third day of the third day to 5 days, it will be already been recovered. So most of the time when we made a call or try to contact these healthcare workers, they are already in a situation where they already overcome that first hurdle. And but still we would offer them, because we do have some who still have problems. For example, like I mentioned here, some of the cases, although it was beyond the team, there were cases that they were ostracized or even stigmatized by their own housemates and also their neighbors, and this is beyond us. But what we can do with this kind of complaints coming from the healthcare workers is for them to develop their own strength, and that's how the PFA works to overcome that. And also we do have cases whereby healthcare workers, once they become patient and then they found themselves to be not getting the attention. For example, nurses, when they work as nurses, they give as much attention to the patient, but the moment they become COVID positive patients, they don't get it. So that is one of the reasons where they felt like either they are not getting attention or they are getting too much attention. So these are the issues that we face, and we are able to talk to them and to eventually provide them with the needs that they required. Okay, then I move on to the a couple of studies where we can actually come out with the potential or possible needs that needs to be addressed. Yeah, this is the study done by Dr. Hemavati from our department, and we can see that although it is more of the study that looking at the psychological experience and perspective of the frontliners, but as you can see here, there are themes that came out from the study whereby negative emotion is rather prominent here, and you can see the words like fear, COVID-related anxiety, work-related fatigue and exhaustion, and feeling sadness and disappointed with the system, and felt lonely when they were forced or being told to be in quarantine. So these are all the negative emotions. Sometimes they were unable to convey to the psychosocial support team. And as you can see here, having a very good support system that helped them in terms of their coping strategy. This is also another study conducted by various departments from our department as well as other departments as well. And this is actually looking at the coping with regards to their own religiosity or their own faith. And not surprisingly, because most of the research has shown that having a very strong spiritual or any faith during the trial times, it helps in terms of the coping to be able to go through the challenges. And this study found that there's a positive the presence of this study found that actually having a positive religious coping predicted a reduction in anxiety as well as the depressive symptoms. So I think with all of those evidence, we can say that how do we meet the unmet needs of the healthcare workers at least in New Stimulary Medical Center? So based on those self-report, the outcome of a couple of studies that were done, we find that, or we hypothesize that actually in order to fulfill the psychological needs, there's a need to for the organization to consider telepsychiatry or probably telecounseling to make it sound a little bit more milder than talking about telepsychiatry, to be made available. And of course, there are a lot of things that we need to consider as well in terms of the security and in terms of confidentiality. And also we hypothesize that psychologically, most of the healthcare workers would need a kind of individualized self-care and spirituality, as we have seen earlier, that it actually helps, especially for those who do have their own basic belief system. And one thing that we notice in most of the research, it shows that resilience as an outcome of our healthcare programs should be the target. Rather than getting them to overcome their psychological needs and support, we would want to have a program where resilience will be imparted to our healthcare workers in order for them to come out of these difficult times bigger, stronger, and healthier. And having peer support group in the workplace is also another needs that we would consider. And of course, in terms of the social unmet needs, we would feel, or we would hypothesize, that having a more caring, non-biased, non-judgmental leaders in the organization or in the department, it will be a major contribution to the well-being of the healthcare workers. And also by the organization to provide a therapeutic working environment which would promote empathy, and that will be of a great help. I would like to highlight this paper, which I think in a way it helped us as as an organization that would love to look into the overall well-being of the healthcare workers, and in which this article is actually a review article. It reviews the organizational interventions provided by the local institutions from various parts of the world. And this is actually a paper that respond to the needs of, to the call of the WHO or World Health Organization, that from the day one the pandemic was declared worldwide, every institution, hospitals that provide care for the COVID related illness should have a protocol. And Alhamdulillah, it seems like from this paper, our protocol has been selected. And I'm proud to say that our remote psychological first aid has been cited by many papers. And as this is, although I'm sorry, if you're interested to read through the paper, you may try to look for this article. And there's one table where it actually tried to look at the 7 different interventions, and we actually represented Malaysia. And as you can see that in China, in United States, Italy, and France, they provided different varieties of psychosocial support. But however, as you can see that there is a common target or objective for the interventions. And even more interesting that I would like to highlight here is, although in most of the situation we would want the psychiatrist to come in and to lead this kind of program. However, as you can see here that in China, who actually they are the primary source of input during the first outbreak or the first wave of pandemic, the psychologists play a lot of role here. And here psychiatrists, and in another hospital, as you can see here, that they actually managed to develop or build a center called Office of Wellbeing and Resilience. Yeah, here we can see that they provide a program called Battle Buddies, and again, interestingly, it is actually led by the anesthesiologist, and also, of course, with the help of the psychiatrists and psychologists. And the author of this paper, interestingly, actually cite his own work, actually, but never mind. But the most important here is what we notice is he is actually an occupational physician. He's not even a psychiatrist or psychologist, but he is able to look at the whole COVID-related issues as a work-related problems. And therefore, his programs is actually to prepare most of the healthcare workers affected with this COVID-19 pandemic to become resilient and to be able to detect or screen for any of the healthcare workers having COVID-related issues or having psychological issues before deploying them to any COVID-related activities or care. And here in France, they actually work with administrative sites, and they are actually focusing more on creating what they call as a bubble. And this is actually creating a therapeutic environment for the healthcare workers. So I would like to share here that in early April, actually, our department has already almost similar to what has been discussed in that slide. We managed to actually come out with this collaborative team. As you can see here that myself and Dr. Benedict take up the research and training of the programs, and we have got program coordinators in our department, Mr. Khairul, Puan Hazwani, and Puan Nuchahaya. And our collaboration with psychology and counseling management unit, definitely Puan Sohaila and Encik Johari. And very important here that we have included nursing under Puan Hashimah Zainul. So this is our program that we have embarked. And let me just spend, I think, 1 or 2 minutes to explain here. It's a bit too much of boxes and colors here. We have initiated this program we call Mindfulness at Work and Relaxation, or MAWAR, in order to provide support group where we name as Wellness, Compassion and Resilience, or We Care at UMHealth support group. However, unfortunately, in June, the MCO was announced and we were unable to proceed. But on paper, so far, we have already have decided in terms of our providing virtual CBT, which has already been conducted successfully by Dr. Ahmad for the Department of Anesthesiology. We will probably continue with that. And also, following our training with the nurses, we would want more nurses to be recruited to be the PFA responders, and that will be our target for the timing. And with this MAWAR program, we will definitely will have to probably to present at the level of the administrative level. And as you can see here that we would be happy if you are able to get the IT department or OSHI unit to come on board, especially to manage COVID related problems, because this is actually in relation to the occupational health. And of course, OSHI can work with us in terms of identifying how do we improve on the compliance program, how do we handle issues related to vaccine hesitancy among our staff, and also to prepare our healthcare workers who will be given COVID-related tasks. Because as we know, not everybody, even though we are doctors, are at ease when we were told that you are supposed to go to the COVID ward to manage the cases. So I think it is about time that we have a pre and post assessment of staff and when we are deploying our staff for COVID-related programs. And this will be our hope, that if we're able to create more and more MAWAR programs, we will have more and more We Care support group. So as we can see here, this will be our vision. We can have more peer support group, and probably with the help of the IT department, we have apps where the healthcare workers will be able to actually use it in order to track their own wellness. And we can also provide different methods of self-care. It can be in terms of mindfulness, spirituality, hypnotherapy, and so on. And also, we will be focusing more on the resilience program, and eventually we'll be able to have the hospital to provide what was done in France, where they have this bubble thing where we provide an infrastructure in order to have a therapeutic environment for our staff. So I would like to end my presentation. As we all know that PFA is for everyone, and PFA can be conducted by professionals and non-professionals alike, non-mental health experts. This can be actually done by just anyone who are passionate in helping people. And we have to know that safeguarding mental health of our healthcare workers during COVID pandemic especially should be the priority and be shared by everyone. And of course, we need to overcome issues with regards to stigmatization. And of course, probably it's about time for us to consider a remote PFA or telepsychiatry as part of the programs. Thank you very much.
Thank you very much, Dr. Zuraida, for the presentation. I sincerely hope that the attendees for the webinar gain a lot of information with regards to the remote PFA that was conducted and still being conducted at the hospital at this point in time. So Dr. Zuraida, we currently have 5 questions already in the Q&A box. The first question: do you have equivalent arrangements for distressed public?
As for now, our focus or task given to our department is to manage issues related to psychosocial factors among the healthcare workers. We would love if we can work with the primary care team, for example. But as for now, I think the issue with pandemic is still ongoing and is still active. And now we have issues with vaccination as well. So I think for now, our focus would be more on healthcare workers, and probably in the future we will go to the public and the communities as well.
Yep, I agree. The second question, Dr. Zuraida, the PFA consultation with healthcare workers documented. How do you ensure confidentiality of the consultation?
Okay, as I've shown in terms of the flow in one of the slides, confidentiality are the first thing that we actually talked about and discussed in detail. And with that, while we were collecting data from the resource unit, for example, from the OSHI, all of this data would have to go through consent from the healthcare workers, and then will be collected by the person in charge. They'll be the same person from day one until now, is the same person. And after that, during our conversation, we have our own sets of the do's and don'ts of remote PFA, in which the person in charge do not share whatever that been discussed, because we actually do not record the conversation. We do not screenshot whatever that we convey through our WhatsApps, and it's actually all the mental health experts plus the psychosocial support team already adhered to the so-called confidentiality, and that has been ensured. Up to now, we do not have any issues with regards to that. Yeah.
Thank you, Dr. Zuraida. The third question, with regards to the source of referral, how do the Public Health Department, Staff Health Clinic or OSHI screen or identify healthcare workers that might require PFA?
Okay. Thank you for the questions. Actually, staff, because it would be good if we can have a proper discussion involving the rest of the teams. But however, the selection criteria that we actually provided to the resource center is very clear. They are the healthcare workers, and they are actually up to today, we are still adhere to the criteria of those who are actually positive COVID, and number two are they under surveillance or quarantine, and these are the healthcare workers. And again, like I've mentioned, most of the cases earlier were referred to us were rather late in the process. It's probably because of the issues of transferring the data, or probably in the selection during the time people get overwhelmed. So by the time it reaches us, it's already the healthcare workers already in the state of recovery. Yeah. So I hope I answered the question. Basically, they are selected and offered PFA to the healthcare workers the moment they were COVID positive, and by explaining to them that there is such interventions. So those who agreed the consent, and then will be referred to the CDCU center. Yeah.
Yep. There is a first question, Dr. Zuraida. This person said that he or she may have missed it earlier, but how may someone be able to get PFA? As mentioned earlier, there is stigma and reservation generally to admit that help is needed. It should ideally be easily accessible with few barriers, step, weights, clinics directly if possible. And there is actually a follow-up question on that. If solely for COVID positive, what about the overworked, burnt out frontline workers?
Okay, so like I have mentioned, we have been having a series of meeting chaired by Prof. Hatim, and of course Cik Khairul also there. So together with Puan Suhaila, because Puan Suhaila and Cik Johari, they received the bulk of the cases directly, and this is where most of the cases that were seen by Puan Suhaila, I think she has the most. She'll be able to respond to most of that kind of question involving stigmatization and so on. But the ones that we received, most of the time, they like I said, there's evidence of hesitancy among healthcare workers to receive help via phone calls. But I think with respect to the frontliners who are not COVID positive, who are not under surveillance, I think it's about time that we are trying to look into these issues. And as I mentioned earlier, that we already initiated a program with the nurses department in order for the nurses to come in and help out in terms of managing the healthcare workers, the frontliners, to overcome issue with regards to the psychological problems. We will definitely be embarking on that program or project. Yeah,
Yeah,
pretty hard
I
for that.
agree. Another question, that is Zuraida. May I
Do we
know?
have time? I think,
Yeah.
is it
Thank you very much,
okay?
Khairul and Dr. Zuraida.
Yeah,
I think we are
I,
short of time.
I think we
I
need to
see.
move to the next slot. We will
That's okay,
answer
Doctor. I think maybe we can type the answer.
yeah. Okay,
Yep.
thank you very much.
Thank you very much, everyone. Now I will pass over to Prof. Adina.
Thank you. Thank you very much, Khairul and Dr. Zuraida. That was a very interesting and important presentation. So without further ado, I think I just go on to introduce the next speaker. So my name is Adina. I'm from the Department of Primary Care Medicine, and I'm honored this morning to introduce the second speaker for breakfast at UMHealth, who is Associate Professor Dr. Sherina Hanafi. Prof. Nick really needs no introduction. She has led the primary care department in UM and UMMC for more than 10 years, and many positive changes has occurred in the department under her leadership. She is also a homegrown talent. She completed both her MBBS and Masters in UM, only leaving to pursue her PhD in the University of Manchester on patients' healthcare in primary care. She has varied research interests throughout the years, but the recent most notable involvement would be her involvement in the Respire project, which is a global health research unit focusing on respiratory health in Asia, funded by the National Institute of Health Research in UK. She reminded me that this morning's talk is not so much to do with new findings or research, but issues with communications, which we doctors grapple with daily. So without further ado, the platform is yours, Prof. Nick.
Right. Thanks, Adina, for the kind introduction. Assalamualaikum and good morning, everyone. Welcome back to work after our one-day break. I'd also like to thank the committee at the breakfast at UMHealth for, organizing these sessions and giving us topics to keep updated with. But following on to what Dr. Zuraida has also presented just now, I'd like for all of us to step back and revisit a very basic, essential element in our clinical work. Essentially, it's about doctor-patient relationship. So this morning's talk is titled, Where Do We Draw the Line? And what I will do over the next few minutes is to touch upon doctor-patient relationship. I will share with you a case scenario of a recent case that we had. Then I will go on into this issue about being accessible, utilization of doctors' phone numbers, talk a bit about boundaries, and hope to have a few minutes of discussion from everyone in the audience. Now, as we know, doctor-patient relationship is something quite sacred. It's something that is built on trust, respect, and one of it is cornered around doctor-patient communication, because this is one of the things that's very important for successful delivery of medical care. And it's been shown that doctors who are more accessible and informative, the patients are more satisfied because they are more informed with their medical conditions. Patients are more committed to treatment recommendations, and more so in a litigious society, they're less likely to sue their physicians. Hopefully, we do not yet get to that extent. Now, over the years, the nature of this relationship has evolved. From early on, illnesses were basically essentially physical, but over the years, it's taken on a rather comprehensive biopsychosocial approach. This was just visited by Dr. Zuraida just now in talking about psychological first aid. The advancement of communication technology, be it mobile phones, emails, web-based platforms, even teleconsultation, has really enhanced communication channels and made the doctor quite accessible to patients. Do patients really want open access to physicians? a quick answer is yes. And there has been several publications on this, but I just want to highlight that there are quite a number of papers that's been done looking at our surgical colleagues. For example, more than 80% of patients surveyed would consider calling their surgeons on their mobile phones. And looking at IBS patients, quite a number, more than three quarters really, ranked their personal physicians as their most desired source of information. And many patients expect their doctors to be available by phone or via email. But for the intent of for the purpose of this talk, I'm just going to focus on mobile phones. Yeah. Now, I'm going to introduce you to Mr. T. Mr. T is a 68-year-old retired teacher, and he's been seen in our clinic, primary care clinic, since the year 2000, and that's more than 20 years. He's got a multitude of conditions, diabetes, hypertension, hyperlipidemia, and chronic kidney disease. Along the years, remembering that it's over 20 years that he's been with us, he's developed renal calculi, he's got bilateral cataract, still waiting for surgery, on and off he's got his infected earwax issues, and occasional viral fevers that he seeks attention for. Now he's got essentially 3 doctors who look after him. He started off with Dr. A from the start, year 2000, and Dr. A had been looking after him all the way until about 2014 when she went off. Now let me show you this in a timeline. When she went off, his care was transferred to Dr. B. Quite recently, when clinics had been postponed, and as well as because the patient had more needs for clinic visits, Dr. C was also roped in to take care of Mr. T. Now, their profiles differ. Dr. A had actually given her phone number to Mr. T many years ago. Dr. B does not give out mobile phone numbers to patients, so Mr. T doesn't have a phone number. Dr. C is new to the scene, so has yet to decide whether to give or not to give. Now, Mr. T had been relatively stable until 2019, and that's when his health gradually took on more issues. He developed cellulitis of his right foot, needing several visits, treatment. His medication had to be adjusted. His renal function gradually reduced. And of late, the latest medical issue he was having was some electrolyte imbalance, which needed some sorting out. This resulted in multiple clinic visits, and it's not only to our clinic. He needed to go to various other clinics in the hospital. This required few visits to the blood taking center, and as we all know, the COVID pandemic didn't make things easier for him. Now, from April until June, in fact, till June, this patient had been calling Dr. A several times. There's only 5 yellow dots there, but actually it was more than 5 calls because some calls were repeatedly in the same evening. Now let's look at why the phone calls were made. From April 2021, all of these calls were made after work hours. Some were during the doctor's dinner time, and the reasons for calling was he wanted to inquire about the hospital's visiting rules. He wanted to update Dr. A about his own admission to the wards. He wanted to confirm his appointment dates and whether the doctor would be available. But on a more justified reason was when he had onset of new symptoms. So we shall discuss this, but I would like for you to think for a short while, a few seconds, how would you feel if you were Dr. A to be interrupted in your after hours on your mobile phone with these issues? We can discuss this later, but I'll go on to tell you about Dr. A. Dr. A has known Mr. T for more than 20 years, as mentioned earlier. Her reaction to the phone calls was that she felt it was a duty to respond to him even beyond normal working hours. Perhaps it was because of her family doctor training, but essentially she felt that it was rude not to answer. So she answered. Now, why do doctors give their phone numbers to patients? There are various reasons. What I find interesting was that it's a good way to look at patients' progress, and particularly for trainees, certainly that is one of the best ways because your patients are really your textbooks, and you can see whether your treatment works for them or not. Sometimes doctors give it to unsatisfied patients, and in reality, it changes the dynamic straight away because from being rather unsatisfied, the patient then becomes quite has more trust in the doctor, and it works for both of them. Sometimes when we have patients whom we are a little worried about, that's another reason to give their our phone numbers too, so that we know that their progress. This paper looked at utilization of physicians' phone numbers by patients in orthopedics surgical practice, where about more than 200 patients were given phone numbers. They found out there was actually low utilization rates, and majority of the calls were indeed appropriate. Interestingly, no calls were made during the evening hours. Now, why would they call? It is essentially to ask about medication, about therapy, and about surgery. So essentially, when the doctor gives the phone number, the doctor is perceived to be more caring. And somehow patients actually do demonstrate restraint and respect for its use. Now, what they also found was that inappropriate utilization of doctors' phone numbers by patients rarely occurs, not as much as we think. There were only about 12 calls that were made after surgical hours, in the post-surgical period. Majority were made during the working hours. There was only a select group of patients. I mean, those who call would call, and those who wouldn't call wouldn't call. Because electronic medical records became more widely used, then the doctors who received the calls were able to get information whenever the patient called. This issue about remuneration, this can easily be addressed by practices having automatic billing, and generally because physician accessibility improves the therapeutic relationship. There are pros and cons, of course. I'm not so sure where it weighs heavier towards, but it's probably on the cons. But let's look at the pros for giving out your phone numbers to patients. One is it shows trust. As mentioned, it enhances the doctor-patient relationship. It allows you to monitor progress and allows the doctor to respond promptly to urgent issues. On the other side, this is mainly because from the doctor's point of view, it can be seen as unnecessary. There is a huge potential for abuse. Even if the calls were made during working hours, it disrupts the doctor's schedule. There is a huge fear, or in reality, does intrude on the doctor's personal lives, as in the case of Dr. A. And doctors are concerned because they might not have enough information to treat or to handle the questions that the patients may have at that moment in time when the phone calls are made. And there are some concerns about lack of remuneration because, after all, handling a phone call is essentially almost akin to a consultation. Now, let's revisit Mr. T and Dr. A. As I mentioned earlier, that's what she felt about the phone calls. And she's actually very selective on the types of patients that she gives her number to. And there are not that many. But when the phone calls keep increasing and they keep on occurring in the evening, she became bothered. And she sees it as something quite tiresome. And there was a sense of helplessness in herself. How does she deal with it? And this came about because essentially we were discussing about him. So the question that she had was, why can't he text rather than call? She cannot not answer because he might just call back, so might as well answer it there and then. The way she sees it is it's convenient for him, but it's not convenient for her. So how does she tell him not to call? Essentially, and another point is, actually at that moment in time, Dr. A, as you remember, is not her treating doctor. So we need to know that there are boundaries. There is a thing called the Therapeutic Alliance, and that is what is rather implicit, but it is a contract between yourself as a doctor and the patient. And when you negotiate on something, when you agree on something, there's actually mutual cooperation. But it gets more complicated when there is a hidden agenda, a covert agenda, as in this case when the patient's needs becomes more complex. And there are boundaries. In reality, there's a professional boundary which allows a certain structure, a certain framework for you to give out treatment. It allows the doctor a certain framework to monitor and set limits on both of your behaviors. But after a while, there may be pressure to provide response as a friend rather than professional. So that is essentially the question that I ask you today. Where do you draw the line? Now, from finding Mr. T as being rather tiresome, Dr. A began to see him as a heartsink. This term may be familiar to you, may not be, but we need to realize that on top of supporting patients, doctors need support as well. And this again goes to what Dr. Zuraida was saying. There are some ways of doing this. We can share the inquiries, we can share workload, and importantly, you can ventilate with colleagues, which is what Dr. A did with myself. Now, heart sync patients really means well, we know that some patients' behavior evokes negative emotions. Some Groves defined them as initially as difficult patients, and he's got some terminologies. They can be seen as dependent clingers, entitled demanders, I have a right to this and that. They can be seen as manipulative help rejecters or self-destructive deniers. So there are various tips in how to handle each of these groups. But essentially, a heart sync patients who will exasperate, defeat, and overwhelm their doctors by their behavior. Literally, when you see this patient, your heart just literally sinks. And similarly with this Dr. A, whenever she sees his number, her heart sinks. What do you do in such instances? It's been recommended that, interestingly, this is mainly for face-to-face communication. When this first came out, non-face-to-face communication was not really the norm. So it's been advised to use verbal communication to make sure the patient knows he or she is being listened to. It's a challenge, but it might help to really uncover what is the patient's true agenda. Let the patient speak first, and then after that, you negotiate what problems that you need to address. It's really up to the doctor to have essential skills to assume control in the communication. There has to be a stage where you hand over responsibility to the patient, set certain rules, and you need to improve your communication skills. Essentially, the advice is don't enter a debate, more so over a telephone call. So essentially, we've got to remember that, there's some of you who I'm sure give out telephone numbers. I do know colleagues who do that quite freely, and it's not only for medical colleagues, it's even to patients. But when we give out our phone numbers, we've got to remember that we cannot control the distribution of your number. It just goes out. A patient may pass it on to someone else. You cannot recall, you cannot take back your number. Of course, you can ask the patient to delete your number, but it's somewhere there. And don't forget that these calls, like as what happened to Dr. A, if it happens in the evening hours, your partners, your families might be affected as well, because it does take on your personal time. So when the next patient asks you, doctor, may I have your number? There are some recommendations. Essentially, it is to have clear guidelines for follow-up. And it will help if the entire team that takes care of this patient is clear on what the rules are. Make sure the patient knows what are the clinic hours and the appointment, how to set it up, and if you have an urgent problem, what to do. There are skills, there are ways that you can talk to the patient, that you can acknowledge worry on the patient's part. For example, like, you really seem really worried about whatever. I want to reassure you that I'm concerned about your phone calls. I wonder what would be helpful, and etc. I'm sure most of us will know how to handle it. But if the patient has a true medical concern, that has to be addressed appropriately. But also, at the back of our mind, we need to know whether there are signs of unhealthy needs for reassurance. Take a direct approach. I think you just decide whether you are the one who give out phone numbers or not. If you don't, offer an alternative. Provide a work number. You can give your office number or a number that's handled by a staff, with a message to leave their numbers and that you will call back. And when you say we will call back, please do call back, because that is the whole essential bit about the trust in the doctor and patient relationship. There are some countries and some places that have messaging services, or there's a call rerouting, not so much for the doctors, personal doctors, but also for the doctors on call. Quite simply, you can have two phone numbers. You can have one for work and one for personal. It's not a high-tech thing to have two SIM cards in a phone nowadays. Essentially, it's also important to keep your tone casual rather than to show that you're quite harassed by these phone calls. So, conclusion, I'd just like to open this question to the audience, and I would love to have feedback. Would you give your mobile phone number to patients? And this is just focusing on mobile phone numbers. I'm not going into email and so on and so forth. Okay. And the take-home message for this talk would be that we do know that doctor availability increases patient satisfaction. However, being accessible through mobile phones has got its pros and cons. It's very important to set boundaries. And when you're aware of these boundaries, you need to know, you need to recognize the limits that you yourself face and when to reach out for help. So these are my references. Thank you very much for listening. I shall hand over this session back to Adina. And yes, there's a poll now, I think. Would you give your phone number to patients? Okay, so thank you very much. And I welcome any questions or discussions.
Thank you very much, Prof. Sherina. We have a very interesting discussion in the chat.
Really?
So I'll
Okay.
just highlight the comments. I think the first one came from Professor Tengku Sara, and she said that we are trying to be patient-centered, and I think it's related to what Dr. Zuraida was discussing as well, whether we could reach them out through WhatsApp or SMS to the doctors that were in distress. So similarly, she said that she has a liaising person who she pays to filter out her messages and then only message her when that's urgent. And Prof. April mentioned that she make it really clear. I think this is one of the things that you mentioned earlier, the rules and guidelines to our patient, like if you do give out your numbers, when you will respond to their messages or their calls, and that she may not respond to it immediately, when then she does not give specific medical advice over the phone. And Prof. Chan said, the result of the polls is out.
Wow.
You can see.
83% will not give out phone numbers and 17% will give out. Yes, hooray.
So that means we circumvent all the issues that you brought up because we're not giving out our numbers. But I think now with the technology, they can find a way of finding either our email, or they call the department and ask for our number. So I think sometimes they do find a way. And I think Prof. Tengku Sara mentioned someone managed to get her home phone number through questionable ways, but they do, if they want to find how to get to you, they can.
Yeah.
So I think the guidelines that you discussed, I think is very important for doctors, especially young doctors, to consider so that they can deal with these issues better. Because I think once patient already have your number, you do really need to have a strategy of how to tackle the issue. Right, Prof. Sherina?
Yes. There's an interesting comment about getting you as a boutique doctor. I'm not so sure who that's from. There's a comment about a boutique doctor. That's a term I'm not very familiar with. But the comment before that was for anyone seeking advice was to come to see me in clinic or to go to A&E ASAP. That's very true. Ultimately, there was one study that looked at this issue, that it just takes a 30-second answer to reply. You know, you're not well, go to emergency stat. The doctor who receives the call may then call the emergency to facilitate the trip, saying, I've got my patient, Mr. AA, whatever, who will be coming in with this issue. And that helps both parties to be more prepared. So I think about the house phone numbers, I think it's quite a nightmare. But I don't know how many of us have home telephones now. But that is quite a nightmare. I'm not so sure what other comments I need to address because they're quite a number.
There's two questions now. I think we'll just address the question. One was that what would our legal support team advise? I think that's from Prof. Chan.
Yes. So actually there are certain guidelines in setting up the teleconsultation guidelines really for the hospital. We are quite we were exposed to the, I wonder whether you all know about the HIPAA, HIPAA. That's essentially an American-based guidelines that has quite clear-cut, do's and don'ts for online or teleconsultation. But the guidelines would still be the same as in for a telephone consultation. Essentially, if you happen to be in this situation, it is quite important to record, to log on what you say with the patient. So being accessible to the patient's records will help for you to jot down. I mean, your patient called you. If you happen to be in the position that you answered, so it would be necessary to open up the records and put in the date and time and what you mentioned. And the other issue that's being of concern is what happens when the doctor doesn't reply and the patient gets into trouble. So there's always another caveat that when you give out the number, for example, as was mentioned earlier, if I do not respond, please do the next step. Don't just wait for me to respond. If you can't get the doctor, then please go see the clinic or the emergency department. Yes.
And the next question is from Hussein. I think it's more of a comment as well. In psychiatry, we are very strict about releasing our number to our patients. Generally, he doesn't release his personal number as it might might cross therapeutic boundaries between doctor and patient relationship. I think this actually trigger me to ask, like for some doctors, is the initial asking for your number is a minefield for them because they want this good patient-doctor relationship, they want to have patient's trust, and suddenly patient asks them for their phone number. How would you suggest they deal with that situation?
Yes, so there was interesting write-up about this. If you're a medical student, it's easy to say, I'm a student, I'm not yet trained to give medical advice, I can't give you my phone number, so that helps. But apart from that, then you just have to be quite firm about it. To be honest, the Dr. B is myself, I do not give out my phone numbers, and I just say that I don't give out numbers, but you have this number, and I actually give out the office phone number when I know there will be some admin staff who will be able to take that call. And when I get the message with the patient's that name and number, then essentially you just have to call back. Because it's easy for the admin staff to reach you. They know your phone number. So regardless of where you are, they will tell you, okay, Mr. X called and said to call back. So that's essentially it. But you essentially have to make a stand. It's either a yes or a no. Once you start giving out your numbers, you will be quite okay with giving out the numbers. So it's just being okay with what your decision is. That's all. There's no right or wrong.
Okay, I think for the last one, I think we are overshot already. Chikwan asked, what about giving out your email address?
Yes, so emails is quite a different ball game because whilst it does give you access or give the patient access to yourself, but it is not an immediate thing. You can control the times when you open up your emails. You can control the time when how you respond. However, the issue with emails is, of course, patient confidentiality. Please take note that I have not touched on any ethical issues related to handling phone calls, or emails. But there are more papers on emails. I'm more than happy to share with you. But emails are more accessible, I think when for the head of departments, essentially the KJ email address, you get all sorts of queries on the email.
All right.
Yeah, I think there was one Mohazmi brought up, when you call our patient, they can get and say, no, of course. And that is why many of us do not use our mobile phones. There's always a big hesitancy about using our numbers. And that's why it is advisable to use the hospital landline. But we do know that particularly now in the COVID pandemic, there are 1,001 reasons to call patients, vaccination, Cosmos, home monitoring, etc. And sometimes it's so much easier just to pick up your phone and do it. But you must know that when you call that person has your number. And even yourself, if someone calls you, you tend to call back on that number. So it's an open discussion. I'm more than happy to share comments, and please email me if you have any views on this. And thanks for your comments.
Email, but don't call.
Yeah.
Okay,
but some of you have my number anyway. You're more than happy to WhatsApp or call me.
All right. Thank you very much. I think that's all that we have. Thank you very much for Sherina. Thank you very much, Dr. Zuraida and Khairul, and earlier on. I think that's the end of breakfast at UMHealth this morning. Please come back next week for another fruitful and interesting session. Thank you. Bye.